So I've been working in trauma orthopedics now for 8 months. Have done a clinical rotation and now just finished an academic post too. So what I'm going to do today is just talk to you about some of the high yield topics in trauma and orthopedics. I suppose this is geared towards sort of medical school finals, but orthopedics is such a large topic that I don't think we can cover all of it in one session. So what I think I'm going to do is I'll just talk about a few key presentations that you see commonly as in F1 or an F2 in an orthopedic department. Talk through those in a bit more detail, and then I've got a few other bits and pieces in the presentation. And then what I'll do is that afterwards, if anyone has any specific questions about anything that's orthopedic related, it can be from the talk or out of the, or not including the topic of the talk, we can go through some of those questions as well. As I said before, I can make the slides available to you at the end of the talk, but the majority of the stuff's available on most sort of educational websites, and I've taken a lot of the images from places like Radiopedia and Radiology Masterclass, which are both excellent places to look for radiographs if you didn't know about those already. So my email address is in the bottom corner here. You can take a note of it if you want to email me some questions afterwards, and I'll put it again at the end. And this disclaimer is just to say this is not comprehensive for everything that you will cover in orthopedics. It's not even a small fraction of all things that you would see as an orthopedic SHO, or that you would get in medical school finals. It's just sort of a mix of what I think are some of the most important things, and then some things that are just a little bit more interesting. And like I say, if you have any questions along the way, you feel free to just type them in the chat, and one of the hosts will either read them out to me, and then I can answer them, or I can see some of them as well. Okay. So there's a few cases in this. I think there's only 2 or 3, because like I said, there's just a lot of content in this to go through. But we'll start with one. So the first case is that you're an orthopedic SHO on call, and you've been called to the ED to see Mr. Smith, who's a 55-year-old gentleman who's presented with a 1-day history of a hot swollen knee. So I suppose the first thing I want to know from you lot is what sort of things would you want to know about this chap that you would probably get from the referral from the ED doctors. If I could get some people answering in the chat, it would be really good. I don't want to just be talking to myself the entire time. So yeah, if we start, before we go through differentials, which I know what the question is there anything from the history you might want to know? So I've seen recent trauma, how long it's for, and there's some very good differentials here. Character of the pain, yeah, and other symptoms. Family history, are they systemically well? Yeah, weight bearing status, all very good things. So I mean, yeah, so those are all key things that you'd want to know from the history. And in terms of those differentials that people were given at the start, I think you've covered a lot of them really well. I think if people could tell me what they think the most important differential in this case would be, if you could type that in now, and then we can go through that. Yeah, so septic arthritis. So that is the most important differential at the end of this case. I mean, we don't know a lot about this patient, but we know that he's got a hot swollen joint, and it's a very acute onset. So what features in a history might make you think that it's septic arthritis? So current illnesses, red hot swollen joint, hot to touch. Yeah, so I mean, we already know that it's acutely hot and swollen, but then you'd also get acutely hot and swollen in gout. It's what other features of septic arthritis? So a history of an infection might indicate a septic arthritis. Recent surgery could be trauma, injuries, weight-bearing difficulties. Yeah, so the main thing, I suppose, is that it's an acutely hot swollen joint and they're unable to weight bear. Now you might think, how is that different to in gout or in pseudo gouts? But the truth is that a lot of the time it's not really possible to tell straight away from doing that. What you'd have to do is you'd have to clinically assess the patient. So that would be taking a history, doing an examination of the joint, and then also some investigations. And I think the most important investigation here would be it's not even come up here, the joint aspiration. So the joint aspiration would be the most important thing, and what we're looking for is a gram stain and for crystals. I think another important thing to mention here is that unlike in most cases of sepsis and things where you would immediately start antibiotics, it's preferable in this case actually that you don't want to start antibiotics, because if you do, if you give antibiotics and then you take your aspirate sample, that's not an ideal situation to be in, because then you might not grow anything, and then you might not know what antibiotics and sensitivities to get. I think this is incredibly important, especially when it comes to prosthesis. If you as a SHO give antibiotics to someone who's got a knee replacement or a hip replacement that comes in with a query infection of that prosthesis, they won't be best pleased. Okay, so you need to think about, as much as you want to manage the patient and treat the underlying cause, you also want to it's a risk benefit of the investigation as well. You want a definitive diagnosis of septic arthritis. So what are the investigations for crystals? So, well, does anyone know why do we look at crystals? So when you send off a joint aspiration, that you send off for quite a few things. So some of the things you send off for include a cell count, and what you're looking for is white cells and red blood cells. You look at glucose. You can do the fluid protein as well. You can also look for a gram stain and do a culture. So the main reason we do, the reason we look at crystals is that you can get crystal arthropathies, and the two main crystal arthropathies are gout and pseudo gout, which are listed here. So gout is caused by uric acid crystals, and pseudo gout is caused by calcium pyrophosphate crystals. Now, under a microscope, and under specific plane polarized light microscope, you get very different crystals. So for gout, you get these negatively birefringent crystals, and then in pseudo gout, you get these positively birefringent crystals, and they have different appearances. Essentially, what you're looking for is whether you've got uric acid crystals or calcium pyrophosphate crystals in there. You may be negative for crystals, in which case it's not a crystal arthropathy. The other thing that you might want to do if you're looking at gout is also do a uric acid in the blood, uric acid blood test. Now, it could be raised, but it's not necessarily raised during acute attack either. So if you do get a normal uric acid level while someone's having gout, it doesn't mean that they're not having gout. So I think that's another important thing to remember. So I haven't got a slide on the management of these, but essentially the management for a septic arthritis, does anyone know what you would do? So, I mean, you would give antibiotics, but it also depends on the joint and how bad it is. I mean, what you actually tend to do is you would wash out these joints too, because the problem with giving antibiotics is you don't necessarily get that penetration into the joint. So you usually have to take these patients to theatre pretty urgently and do a joint washout too. Okay. And then what about for gout? How do we manage gout usually as an inpatient? So in terms of the question is that the same for osteomyelitis? Now, that's not necessarily. So patients with osteomyelitis don't necessarily need debridements and washouts. They can be. It all very much depends on a case-by-case basis. And they can actually be managed with long-term antibiotics, and that the antibiotic that's used very much depends on sort of the microbiology team and what cultures say. So you're usually guided by your infectious diseases team or your microbiology team at your hospital as to what you can give. And usually these patients are put on their sort of the OPAT or at UHCW we call it hospital at home type service, where they'll have a long line in situ, like a midline or a PICC line, and they will have once daily antibiotics at home, just because they need them for long term. How long do you give antibiotics for in septic arthritis? Now, that very much depends on the causative organism and the degree of the infection. It's usually for a longer term, but again, I wouldn't know that off the top of my head. Again, it's very much dependent on your sort of local guidelines. With anything, when it comes to anything with your with antibiotics and infections, the answer is always to check your local guidelines. And the reason for that is that different causative organisms have different prevalences in different areas of the country and different trusts, and that's why the guidelines are local and not national. There are sort of nationalized guidelines in the BNF, but they're sort of superseded by your local sensitivities. So always consult your microbiology team and always consult your local guidelines for choice of antibiotics. Going back to sort of the management for gouts, so there are a few different medications you can use, and NSAIDs are usually the most commonly used. But again, NSAIDs are plagued with the problems of their own, and they're contraindicated in a lot of patients too. And will require PPI cover if you do use them for a longer term. Colchicine is another option that you can use, and then if the gout is resistant to both of those, you can also opt for corticosteroids too. Someone has written that allopurinol ? So allopurinol is used, but it's used as prophylaxis for gout. So generally, if the patient's only had one episode of gout within the year, you wouldn't start allopurinol. It's usually reserved for people who've had more than one attack within a year or have frequent episodes of gout, and then they would be starting on allopurinol. And that's usually started in the community and not in hospital. The thing with there's sort of two schools of thought about starting allopurinol. There's the one school of thought which says that you shouldn't start it during an acute attack of gout, and that's sort of what's in the NICE guidelines. So I would sort of stick with that. You should wait for 2 weeks after an episode of gout is finished before you start allopurinol. However, so the reason for that is given allopurinol can cause a flare essentially, or make you more susceptible to a flare in the short term. So that's why whenever we treat patients, we'll start treating patients with allopurinol, they're usually given colchicine as cover, to prevent the uric acid crystal buildup and prevent the symptoms of gout. So that's why that's done. And that can usually be for quite a prolonged period of time, so a few weeks at least, for them to have the colchicine. So in that case, NSAIDs are not always appropriate, especially with the longer term use and in patients that it's contraindicated in. So colchicine is used as cover. So the second school of thought, as I said, is that as they're having an acute flare of gout at the moment and they're already taking colchicine, some consultants would argue that you could start the allopurinol during the acute flare of gout and then continue it afterwards. So that's just something to consider. If we talk about pseudo-gout briefly, so does anyone know any risk factors for pseudo-gout? Yeah, hypothyroidism. Yeah, saying I can see a lot of the more sort of rarer risk factors. I think so your big risk factor that you might see people come in with is actually osteoarthritis. So people with osteoarthritis are more likely to have pseudo-gout as well. So pseudo-gout generally affects different joints to gout. It affects a more large joint. You usually get it sort of in your knees, although you can get gout in your knees. So gout you can actually get in any joint in your body, and although it's described as a monoarthropathy, you can actually get it as a sort of polyarthropathy picture. So you can get multiple joints affected at the same time with gout too. I don't really have much more to say on pseudo-gout. You don't see it that often in hospital. The things that you see most often is gout. Septic arthritis is again not very common either, but it's sort of your most important, red flag type diagnosis. So it's something you always need to be on the lookout. This image just in the sort of top right is just it shows you sort of the different routes of infection that you can get to cause a septic arthritis. And a lot of those were mentioned earlier. So you've got your penetrating trauma, your other infections or sepsis, which has been transported via the hematogenous route. You can get adjacent local soft tissue infections and osteomyelitis that can invade the joints. And actually, the other thing that to be really careful of is that when you're doing your joint aspiration, and you have to really again, it's sort of that risk benefit type thing, is you run the risk of introducing pathogen into the joint. So if you're not suspecting septic arthritis, then clinically the patient's not septic arthritis, you shouldn't aspirate the joint unless needed. Okay, right. So I think that's for the swollen knee sort of thing. That's all I really wanted to talk about for that for now. And I think we should talk a bit about trauma. So the majority of what I'm going to talk about today is about trauma. We'll touch on a few other things as well towards the end, but the majority is going to be lower limb and some upper limb trauma too. So just when we're talking about trauma and fractures, so the definition of a fracture is a break in the continuity of the cortex of bone with an associated soft tissue injury. So by definition, every person that has a fracture also has a soft tissue injury. I think that's important to remember. So the actual break in the bone causes a soft tissue injury as well. So when people say that people have just got a soft tissue injury, well, they might also have a fracture. This is something to consider. What's the treatment for pseudo-gout? So that's just it. Again, it's your anti-inflammatories and sort of conservative type management. Okay. So how do we classify fractures? We talk about fractures in a lot of different ways. We use lots of different words. These are just a few. These ones listed are just a few of them. The reason we use all these words is it helps us by classifying fractures, and by talking about them in this way, it allows us to get a picture without seeing the imaging, but also as to what the management would be and what we would need to do for these patients. So I've got these terms here, and on the next slide I've got some definitions, but I want people to just have a go at defining some of these terms, or just saying in the chat what we mean by these terms. So when we're talking about closed versus open fractures, what is it I'm actually talking about? So yeah, so whether the skin is penetrated. So I mean, okay, I've got a scenario for you then. So the patient has got, say, this tibial shaft fracture that's on the screen. This wouldn't happen, by the way. This is just a scenario. So this tibial shaft fracture is on the screen, and there's a break in the skin up here. Is that an open fracture? So Yasmin, you said no. So why? Yeah. So in terms of an open fracture, and it's not just about the skin. So there's a break in the skin, but it also communicates with the underlying fracture or the fracture hematoma. And by that I mean the sort of blood around the fracture. And yes, of course, unless the proximal part of the bone is affected too, but in this case, we're just taking this one isolated fracture that's on this graphic. So that's closed versus open. So closed fractures, there's no break in the overlying skin. Open fractures, there's a break, but it communicates with the fracture. So these, so a lot of the times when you think about open fractures, you think about these big fractures, big cuts with bits of bone sticking out. They don't always have to be like that. So an example of a recent case I saw was someone that had a bimalleolar ankle fracture, but had an overlying wound just overlying the lateral malleolus. And whilst it looks very innocuous, actually, if you explored the wound, and it was only a very small, so maybe ½ centimeter wound, but if you explored it with a wound probe, you'd actually see that it went all the way down through to the bone and to the fracture, and that in itself is an open fracture. So it's important to make sure that you're aware of that too. It's not just the big wounds with bones sticking out or bits of fracture sticking out. You know, they can be small lacerations that go into that communicate with the fracture as well. So why do you think it's important that when we're talking about open fractures, why do I want to know if it's an open fracture? Does anything change if it's an open fracture to a closed fracture? So yeah, the main thing is the risk of infection. Okay, so if it's a closed system, it's not exposed to the outside environment. So with the skin, you still got that skin layer which acts as sort of your mechanical barrier between the outside world and your fracture. Just like as we spoke about septic arthritis, you increase your risk of infection of your soft tissues, but also an osteomyelitis with an open fracture. So the big thing with open fractures is they need to have a good washout as well as their definitive management. So we spoke about open and closed fracture. What about what's a simple fracture? No, and yeah, I guess I get that it's not a comminuted fracture, but using the opposite word isn't sort of what I'm looking for. So it's not about displacement. So we've got displaced and undisplaced to describe displacement. So yeah, so it's a single fracture line causing two fragments. So that's a simple fracture, okay? So the opposite to that would sort of be your comminuted fracture, and that's where you have multiple fractures. So multiple breaks called multiple fragments. Okay, so your simple fracture is one single fracture line causing two fragments. Your comminuted fractures are those that have multiple fragments from your fracture. And then as we've already discussed in the chat, you've got displaced versus undisplaced fractures, and that's to do with how displaced or the alignment of the fragments. And then the last term here is pathological fractures. What do we mean when we talk about pathological fractures? So it's not necessarily from low energy trauma. So it's from an underlying pathology, essentially. It's from a pathology that causes the bone to be abnormal. So that could be osteoporosis. That could be your metastases causing or bone tumors that cause your fragility. So they can, and they often are associated with low energy injuries. And low energy trauma, but it's the fact that the bone itself is abnormal and is not of a normal or strong quality. And all I've done here is I've just defined all those terms for you. So as we've discussed, these are the definitions of those things. Okay. So when we think about fracture management, there are sort of three principles for your fracture specific management, but we don't just have a fracture in front of us. You know, we have a patient and we have to treat all patients holistically, so we need to make sure that we consider everything else. So it's not just about managing the fracture. The severity of fractures varies depending on as we spoke before about the mechanism of injury. So whether it's high energy, whether it's low energy, what type of trauma is it? Is it a sharp stabbing trauma? Is it a sort of blunt force type injury? And all the other different things that are involved in your mechanism. So with your sort of higher, with your sort of higher energy and your multiple fractures, high energy trauma, high energy trauma, and multiple injury type patients, you want to be following the ATLS guidelines. But one of the questions is, would you recommend learning the ATLS guidelines? I would say no, because there's a whole course dedicated to doing ATLS, which if you're interested in surgery or emergency medicine, you would do between your F2 and CT1, CT2, ST1, ST2 levels. Essentially what you're doing is it's a modified A2E assessment, the ATLS. The difference is it accounts for major blood loss and traumatic injury, so also C-spine immobilization. So those are just things to be aware of. So the answer, I suppose, for your OSCEs, you would be correct in saying an A2E assessment, but you would also be correct in saying the ATLS guidelines. If you were to go to do further exams, like I said, in emergency medicine or surgery, the ATLS guidelines are what you'd want to be saying, because that's your more modified approach for your trauma patients. So we follow the ATLS guidelines. We'll come on to history in a moment, because I've just had a question about VT prophylaxis and does it differ in any way in orthopedics. So NICE produced some very good VT assessment guidelines, and most hospitals in the country will have their own sort of VT prophylaxis guideline and their risk assessment tool. Essentially what you're doing is you're following that risk assessment tool. The thing I would say is that a lot more patients in orthopedics become immobile because they have traumatic lower limb injuries, and in which case they're not able to be mobile. So you need to think about longer term chemoprophylaxis for those patients. For most patients who have surgery or are admitted with a surgical problem, they will need to have both chemoprophylaxis with either Clexane or an alternative similar to Clexane, which is enoxaparin, and mechanical prophylaxis, and that would be TED stockings or Flotrons. So at UHCW, what we use for patients who have neck of femur fractures is we use Flotrons and Clexane, and then anyone who remains immobile, so that's with maybe tibial plateau fractures or they have X fixes in situ, they will go home, and usually with a month's worth of Clexane, which will generally be reviewed when they get seen in fracture clinic. So again, the answer is very much like the antibiotic guidelines. It's VT prophylaxis in line with the guidelines, so the NICE guidelines and the VT risk assessment tools that you have. Going back to sort of your history, so a lot of the things that you said for the chap with the knee swelling apply to anyone with trauma or with fractures. You want to know the mechanism of injury, and what that is it's not just how they did it, but you want to know all the factors about it. So if they're in a road traffic collision, you want to know whether they're wearing their seatbelt, how fast they were going, whether they collided with something stationary or whether they collide with something moving in the other direction or something moving in the same direction. Those things all play a role, and they allow you to determine whether it's a high energy or a lower energy type injury. As like I said, the patient is a patient and they're a person, they'll have comorbidities, and we need to explore those comorbidities. Things like whether they're taking warfarin or a DOAC is really important to know. It also influences any sort of surgical decisions making process that occurs, and would require a discussion with the anaesthetists, especially when it comes to stopping anticoagulation. And you also getting a rough idea of their fitness for surgery. So you get a very good picture from the history and talking to the patient. There's a very big difference between a 62-year-old chap that's walking every day, does lots of gardening, to say a 90-year-old who's from a care home, is bedbound, has lots of comorbidities, you know, and those are things that you want to also be considering. As well as doing that, so you know, as part of the ATLS protocol, you do your A2E assessment, you also do your secondary survey, and that's when you look and identify any other injuries as well, and that's what you want to be doing for anyone that comes in with a fracture. They may not just have the fracture, they might have other injuries that will also need dealing with too. Sometimes they are more important than dealing with a fracture, so you need to think about that. So it's all, especially in your trauma situations, especially in the major trauma centers and tertiary centers, is the trauma call and the thing is a multidisciplinary, multi-specialty approach. Some of that's when you start collecting in a surgical patient. So generally you start it on admission for most patients. Again, generally, and again, it all depends on guidelines and what your anaesthetist says. But at UHCW, it's okay to give patients the Clexane, the dose before the night before they go to theatre. You wouldn't, because usually given at 6 o'clock, and then by it's at least 12 hours since they go to theatre. I wouldn't give it after that. And then generally you could start Clexane straight away after theatre too. So you don't really have to wait. I think you usually have to wait about 6 hours post-op. Which is the guidelines at UHCW, but again, consult local guidelines, and if in doubt, discuss it with the hematologist. They'll know. So now that we've spoken about general management, I think the thing to talk about is the principles of orthopedics, and it boils down to sort of 3 core principles when it comes to fracture management and actually most injuries. And that's reduction, and then holding or immobilizing, and then rehabilitation. So reduction can be done either open or closed, and it can be done in the ED or in theatre, and then the same with the sort of your immobilizing. You tend to do both of these steps together, but you might, depending on the injury, you may do a reduction and then do a further reduction and immobilization in theatre. So in terms of ways that we can immobilize patients, so we can do things like simple splinting. So that could be things like using buddy strapping of fingers, or using splints like Futura splints on forearms and hands. We can use plaster of Paris, and we can use fiberglass casts as well. And then in terms of our operative types of fixation, we have internal fixation, which is your screws, plates, and that type of thing. And then we have external fixations, which are our big frames and external fixators. Does anyone know anything about plastering and well, just anything about plastering and the differences between sort of back slabs and full casts and things like that? Okay. So no answers there. So initially a half cast. So yeah, so a half cast is we call it a back slab. So yeah, so the reason, so when patients first come into hospital and when they're first being managed, we tend to apply what was called a back slab. So what that essentially is that's a big slab of plaster applied to just one surface. So if you came with a distal, well, a forearm fracture, you would get a back slab running up the back of your arm and up above your elbow, and that's a big slab of plaster with wrapped up with woolen gauze as well. And the reason for that, as Jerry quite rightly says in the chat, is to allow for swelling. So if we didn't allow for that swelling and we applied a full cast straight away, and then the patient swells up, what would be the consequence of that? Yeah, so compartment syndrome. That's one of the big things. So compartment syndrome usually occurs in sort of your higher energy trauma. Does anyone know what you sort of look for in patients with compartment syndrome? How would you there's the sort of the 6 P's. So can anyone talk me through the 6 P's? Yeah, so there's a lot of good answers there. So pain, pallor, pulsiousness. So yes, that's all true, but a lot of those are the things that you get sort of later stages. So one of my consultants we had some teaching on compartment syndrome a few months ago, and one of our consultants quite rightly said this way. Yes, you get the 6 Ps. Those 6 Ps are pain, 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 and more pain. So the big thing is disproportionate pain. Is pain out of proportion with the injury, and yeah, you test it with your passive stretch. Your passive stretch pain is what you get. So in an initial instance, the first thing you'd want to do if you suspect compartment syndrome in someone that you've applied a cast to is you want to release the cast. Okay, a lot of the time it's not compartment syndrome is what you get. You just get the cast is too tight and there's some swelling, in which case releasing the cast and releasing that pressure is enough. Yeah, so releasing the cast is enough. If that doesn't work and you're worried, escalate it to your registrar and they need to get the consultant in straight away, because compartment syndrome is a surgical emergency. Okay. So let's talk about some lower limb trauma. So another case, you've got Mrs. Jones, who's a 75-year-old. She's brought in by ambulance following a fall at home, and then she's complaining of a right-sided hip pain. What are the indications for internal and external fixation? We could talk about that in a little while, if that's okay, because I think some of those are sort of fracture specific, and I think it'll be best sort of spoken about at the end, if that's all right. So going back to the case, we've got Mrs. Jones. She's a 75-year-old female brought in following a fall at home, and she's complaining of this right-sided hip pain. So the plain films done by ED show that she's got a neck of femur fracture. Okay, so a neck of femur fracture is actually a proximal femoral fracture. Okay, so it's a fracture of what is the neck of the femur anatomically, but it's the proximal femur. So if we have a look at the sort of anatomy of the hip joint, you see that the anatomy, the hip joint is actually is a ball and socket joint that articulates the surfaces of the femoral head and the acetabulum. And the acetabulum has got this fibrocartilaginous collar called the labrum, which sits around it. Now its stability is held by various ligaments. So it's got this first ligament, which is the ligament to the head of the femur, which carries a very small blood supply to the head of the femur. But it's also got the iliofemoral and pubofemoral ligaments anteriorly holding it in place, and the ischiofemoral ligament holding it in place posteriorly. So it's a very, very stable joint. So, native hip dislocations are very uncommon. What you can find in terms of dislocations is that following a Hemi arthroplasty or a total hip replacement or a full arthroplasty, is that patients can dislocate, and that dislocation is usually a posterior dislocation. But again, it's not very common, and I don't think we'll talk very much about that anymore. If we think about the blood supply to the hip joint, so you've got the femoral artery and your branch off it with a profunda femoris. That gives off the lateral and medial circumflex femoral arteries, which mostly supply your proximal femur. Okay. So the important thing to remember here is about this medial circumflex femoral artery that wraps around the sort of the neck of the femur. That supplies the proximal end of the femur too. So you have this very distal to proximal blood supply to your neck of femur and your head of femur. And the reason that blood supply is the fundamental reason why we manage neck of femur fractures, proximal femoral fractures the way we do. Okay. So let's see what the next slide is. Yeah. So we know about the joint capsule is formed by those ligaments and the capsule around it, which is what we spoke about in terms of the anatomy. And as I said, the significance is the blood supply. So when we think about hip fractures or neck or proximal femoral fractures, we broadly classify them into extracapsular and intracapsular, and then you can further subdivide them. And you know, these are not all of the classifications. This is just an image that shows some of the main ones. And I think we'll flip back to this slide in a minute, because I think we can sort of talk through some of the management options with this image quite well. So we classify intra and extra capsular fractures as the main method of classification. You can then further, there are obviously other classification systems that you can do for neck and femur fractures, and for proximal femoral fractures, the Garden classification is the one to learn if you're going to learn any. Again, I don't cover that in this talk, but that's something you can easily look up. There's sort of 4 different, and it's all to do with the displacement of the femoral head. Okay. So the important thing about intra and extracapsular fractures is that in your intracapsular fractures, because the blood supply is distal to proximal, you're disrupting that blood supply. So it can lead to an avascular necrosis or a non-union of the fracture, and that's really important. So it influences the way we manage. So what we would say is that for extracapsular fractures, there is an option for fixation, but in intracapsular fractures, unless the patient is very young and it's completely undisplaced, we would often do a replacement operation rather than a fixation or a repair. In your very young, active, undisplaced intracapsular fractures, you can do a fixation with cannulated screws. So that's just 2 or 3 screws popped through the cortex into the femoral head, and that will hold the fracture together. So when you're thinking about fixing fractures, what you essentially want to do is you want to get a hold at 90 degrees or perpendicular to the fracture. So and then you also want to get good hold through at least through the cortices, so from on either side of the bone. And the reason I say that is that some of the management options rely on these principles, which means that if you can't get a full reduction, you can't get that 90-degree perpendicular fixation, and you can't get a good hold with your fixation, often those are not viable options. So when we think about so we've got to talk about radiographs first. So in terms of your radiographs, you always want to, so I've just got pictures of AP radiographs to show this. Whenever you're assessing a fracture, you need to remember that you need at least 2 views. And the reason for that is that a radiograph gives you a good 2D image, but obviously we're not 2D, we're 3D. We need to get a 3D appreciation. So we need to get that appreciation. And the only way to do that with plain films is to get more than 1 view. So when you're assessing a hip fracture or a suspected hip fracture, the 2 things you would usually get is you would usually get an AP of the pelvis or the hip joint, and you would get a horizontal beam lateral of the hip joint. So you would get a lateral, that's a lateral image. Like I say, I don't have any lateral images on this presentation, but sort of some of the key things that you can think of and the features that you can see in fractured neck and femurs are demonstrated in these images. So on the image to your left, there is a normal pelvis or a normal hip joint, and you see that there's this normal continuation of the line from the superior pubic ramus all the way through the femoral neck down to the femoral shaft, and that line is called Shenton's line. So one of the things you can look for is disruption in Shenton's line, and in the image on the right, there's quite a pronounced disruption of Shenton's line. It's not always that pronounced; it can be quite subtle, but you can notice. You can also see that on the image on the right, the lesser trochanter that I'm highlighting over here has become more prominent. So if you think about what happens when you get a fractured neck and femur, you get shortening and external rotation due to the muscular forces that are working on the fragment. That external rotation causes the lesser trochanter to be more prominent, as you can see here. And then in the image, you also can sometimes get this bone overlap or see an actual fracture line. And those are sort of indicators that you've got a fracture there. So if we're thinking about management, broadly speaking, we split it into intracapsular and extracapsular, and then if it's intracapsular, sorry, that's the wrong way around. I apologize for that. The extracapsular ones are the ones that get fixation. That's a mistake on my part. I apologize for that. It's your extracapsular ones will be fixed, and your intracapsular ones are the ones that will have replacements. So if they've got poor mobility, and so this is very subjective. So generally speaking, if they're using one or more mobility aids to mobilize, and they're not moving very far, we would opt for a Hemi arthroplasty. Again, the age of the patient and all the other factors to play into it as well. Generally, for patients younger and more mobile, you'll want to do so a total hip replacement is where you replace. So there's the question in the chat is what's the difference between a total hip replacement and a Hemi arthroplasty? So a total hip replacement, if you see in the images down below, is you replace, not only you're replacing the femoral head, you're also replacing the acetabular cup as well. Okay, so that's your total hip replacement or full arthroplasty. And your Hemi arthroplasty, all you're doing is replacing the femoral head and the ball. You leave the acetabular cup the way it is. So you're using the native acetabulum from the pelvis. What that means is that the total hip generally has a slightly better range of motion, slightly better function. The Hemi also has an increased risk of arthritis, of osteoarthritis, and you get the wearing down of the acetabulum. So that's so that's the difference between a Hemi arthroplasty and a total arthroplasty, or a full arthroplasty, or total hip replacement. So again, it's about this whether their functional status and their mobility status beforehand. If they've got good mobility beforehand, they're walking, they're not using any mobility aids, they're young, they're sort of more healthy, they can cope with a slightly longer operation. They've got better fitness for surgery. A total hip replacement would be the better option at that point. Again, when I send the slides to everyone, I'll change it around to make sure that the intracapsular and extracapsular are in the wrong bit. I apologize for that. And when it comes to fixation, remember what I told you about being 90 degrees to the sort of fracture line, and that's it. So this is a DHS, or a dynamic hip screw. So the way this works is that this hip screw can slide up and down. It can absorb sort of your compressive forces, but it also causes compression along this fracture line. And you see this fracture line is perpendicular to the screw. Okay, so if that fracture line will say this way, I want to see if I can I draw on this in any way. I can see if I can do that. If the fracture line will say in this direction, you can't use a dynamic hip screw, because they come at the way they come is they come at one angle. They come in the packet like this. There's a screw and a plate, and you put the screw in along the plate. But if in this case, you wouldn't be able to get your adequate fixation, because your compressive forces that you'll need for the fracture would be this way. That makes sense. Okay. Whereas with the DHS, what you're getting is you're getting your compressive forces acting in this direction. Okay. So, and that's because, again, you want union of your fracture. If you're not applying the force in this direction, what you'll get is if you're not applying, you'll get your fixation of your cortices, okay, but the screw itself will slide off. You'll get a shearing force rather than your compressive force. So in this case, you use what's in the middle, or what's an IM nail. So this is, I'll explain again in a sec. So this is an intramedullary nail. So this particular nail is called a TFN, and that's just the model of the nail from the company that produces it. But this is an antegrade nail. You can place nails retrograde as well, down from the distal femur up, if you have a femoral shaft fracture. Okay, so going back to the image that I've annotated, like I said, if you've got this fracture here that's on the image to start with, you get, when you place your screw in at 90 degrees. Okay, if you place it at 90 degrees, you get your compressive forces. Your compressive force at 90 degrees, that holds the fracture together, and that's where you get your union. Whereas the fracture I've drawn, if you place a DHS in there, you're not going at 90 degrees to your fracture sign, so you don't get a compressive force. What you actually get is a shearing force. I think we're going to crack on a bit now, because I think we've gone an hour and we've not really covered very much. So in terms of significant morbidity and mortality associated with hip fractures, there is a lot. So 10% of patients at 30 days will have died, and then roughly around 30% within a year. And that's partly to do with the fact that generally it's a sort of more of a fragility fracture occurring in the older age groups who have a higher amount of comorbidities. But I think the other thing to note as well is that this also comes about from being immobile. Okay, the immobility aspect also has an effect on general health and causes a general decline, which also leads to your increased morbidity and mortality. Okay. So I'm not really going to talk about knee injuries. I'm not really going to talk about knee injuries. Unfortunately, in terms of feedback, it's a QR code at the end. I'm sure one of the founders or the hosts can send that to you. Sorry, I have to leave, and so sorry that this is overrunning.
Yeah, I'll just put the feedback in the link for anyone who wants to click that.
Yeah, so I'm not really going to talk about knee trauma, but just know that these are some of the sort of common type things you see. So anterior cruciate ligament ruptures. So that's typically from a twisting injury. It can be traumatic. It doesn't have to be. You see these a lot. These are very common in football players who do a lot of change in direction. Generally, the mechanism of what you'll get in the history is that you'll hear a pop, and then you get significant swelling within a few hours, and that's a hemarthrosis forming. Tibial plateau fractures, again, generally quite can be high or low energy injuries, and again can be managed conservatively or operatively. It all depends on a case-by-case thing. Your tibial shaft fractures are more likely to be high energy injuries, and generally these will be fixed, but that's not to say that you can't manage them conservatively as well. So this is just a recap of ankle anatomy for anyone that needs it. So your ankle joint is made up of 3 bones. You've got your tibia, your fibula, and your talus. Your calcaneus does not form part of the ankle joint. I think it's important to remember that. And then the stability is held by 4 ligaments. So on the medial side, which is up here, you have your deltoid ligament, and then on the lateral side, you've got your anterior talofibular ligament, your posterior talofibular ligament, and then your calcaneofibular ligament as well. So ankle fractures are very common. You see very commonly seen in the emergency department. They're very common presentations. Just a quick word about the Ottawa ankle rules. So the Ottawa ankle rules are basically, if you suspect an injury or a fracture, it's the rules that you can use to guide whether or not you need to get plain films. So the plain films that you get for an ankle, whilst you'd ask for, you can ask for an AP and a true lateral, but you don't usually get that. So you usually get an AP and then a modified lateral or Mortice view. If you want weight-bearing views of an ankle, you'd have to specify that as well. Okay. The way we classify ankle fractures, and when I talk about ankle fractures in this sense, I'm really meaning sort of your lateral malleolus, sort of distal fibula type fractures, is we classify using the Weber classification. So this classification sort of helps guide our management. It's the most commonly used classification for ankle fractures. But, you know, in terms of your Weber B, which can be stable and so the ankle radiograph views I'll come on to, it's on the next slide anyway. There's quite a few radiographs that we'll go through. The Weber B type ankle fractures, which occur at the level of the syndesmosis and can be stable or unstable, and it depends on whether you have another fracture with it and other things. So you'd want to assess that. Generally, you could use. There are lots of ways to assess it. But you want to assess the stability of the joint. One of the ways is to get weight-bearing views on the X-ray, which you wouldn't do immediately because they'll be unable to weight bear, but maybe a week down the line, if you're thinking whether you can manage conservatively, and you can see tailor shift. Now, you don't really want to be waiting that long. I say a week, it'd probably be a couple of days is more what you want to be doing, because you don't want to be putting someone into a boot who has an unstable ankle, because you'll just make the fracture worse. So as you can see in this image, your Weber A, so your syndesmosis is about here. Your Weber A is below the level of syndesmosis. Weber B is around the level of syndesmosis, and C is above. So Weber C is inherently unstable, and those need to be managed operatively. So yeah, so like I said, it's all about the stability of the joint. So we can do conservative. Well, so for all Weber A's, generally are conservatively managed. There's I can't think of, unless you have other associated injuries, I can't see why you would manage that surgically, because you can manage it conservatively and it has very good outcomes. Now Weber B, so this tailor shift is what I'm talking about. If you have a look at this radiograph here, this is a before and after. So this is a Weber B fracture. It also has this sort of, well, it's a bimalleolar fracture. So it's got this. So part of the reason for this being unstable is that the medial malleolus is also fractured, so it needed fixation. But if you see that there's this increased gap between increased gap here, and that's called tailor shift. Okay. And these are just so yeah, so between the tibial plafond, the medial malleolus, and the fibula, you can see there's that increased space, and that's what is known as tailor shift. So these are normal X-rays, and these ones are just all these are doing is showing you some of the key features. So the fibula, the tibial plafond, the talar dome, and then that ankle joint space, and that's shown on both your AP and your lateral. This is just highlighting where those ligamentous structures will be when you're thinking about it on a radiograph. And then we've got an example. So this is a Weber A fracture, and you can see that in these spaces you've got Weber A. Weber B will be at the level of the syndesmosis, which if you compare onto the other side, that's where that is, and then C would be above. So what we've got here is just a few radiographs. Does anyone know what type of fracture this will be? Yes, that's a Weber B. For the person who asked if I could mark all the Weber stages on the X-ray using a coloured marker, I hope that X-ray image was before was okay. That showed that showed you the three levels of where each one would be. So yeah, this is a Weber B. There's no associated, but you can see. Can you see here? There's that increased space on this side. Can you appreciate that? That's got some increased tailor shift. And again, so on this side, you can see that tailor shift there, that joint space is widened. This is a bimalleolar fracture. So you've got your Weber B type lateral malleolus fracture, and then also medial malleolar fracture here. And then when we think about ankles, there's three malleoli we think about. So that we've got the medial, the lateral, and the posterior malleolus. So this one, if you see here that small fragment that's come off the back of the tibia, that's your posterior malleolus. So this is your Weber B. medial malleolus and a posterior malleolus fracture. So number 1 is your medial malleolus fracture. Number 2 is your Weber-B fracture, and number 3 is your posterior malleolus fracture. Just a differential for ankle fractures when they come into ED would be sprains. So sprains are a ligamentous injury, generally occur after an inversion injury on a plantar flexed ankle. And the most common ligaments affected are your anterior talar fibular ligament and your calcaneofibular ligament. You get significant swelling and pain and fingertip tenderness. Now, these are actually just managed with early mobilization and rest, ice, and elevation. So that's a brief overview of some of the things that we think about with lower limb trauma. If we talk about some upper limb trauma briefly, I know we're sort of running out of time, so we'll sort of run through this quite quickly. We think about the shoulder joint. So the shoulder joint is something that can get a lot of pathology. Again, it's a ball and socket joint, but a ball and socket is used very loosely. It's essentially a ball and a plate. The stability mainly comes from the ligamentous structures, your rotator cuff, which is these sort of intrinsic shoulder muscles, and there's 4 of them, and the glenoid labrum and the biceps tendon. Now, common injuries that you get at the shoulder, as well as getting sort of your proximal humeral fractures, which can cause problems. You get shoulder dislocations and rotator cuff injuries, and both of which are actually fairly common and seen quite regularly within the emergency department. So when we're thinking about shoulder dislocations, the most common type, which will account for the majority of them, would be your antero-inferior, which is sometimes called an anterior dislocation. So this is the general mechanism for this is force being applied onto an extended, abducted, externally rotated humerus. So for patients who have their first dislocation is usually traumatic. Okay, so first dislocations generally occur as a result of trauma. Once a joint has become dislocated, it becomes prone to being dislocated again. So in patients, especially patients that have a lot of hypermobility, they frequently can experience anterior dislocations of the shoulder. Now, because of all those structures I mentioned that stabilize the structure, your posterior dislocations become very uncommon and very difficult to do. They are very high energy injuries, generally caused by seizure activity or electrocution, and can occur from high energy trauma. So if you apply a force through a flexed adducted arm at the anterior shoulder, you can cause a posterior dislocation, but it's very difficult. What you'll see with these patients when they come in is that they'll have an acutely painful shoulder. They'll be holding it, holding their arm in place, and they won't be able to move it. They'll feel that it's unstable. And when you have a look and do your shoulder examination, one of the things you look for is that symmetry, and you'll notice an asymmetry compared to with the other side. You can sometimes see on these patients that they have a loss of their shoulder contour, and they may have an anterior bulge, and that comes from the fact that the head of humerus has been displaced. So the views you generally get for a shoulder, again, are not AP and lateral. What you get is you get your AP, but what you would generally get when you ask for shoulder x-rays is your axillary view or your Y view x-ray. And all I've done here is get some images from Radiology Masterclass which highlight those images and highlight the key anatomy, so the head of the humerus and the glenoid. And the reason we want to do it specifically on the Y view is that I want you to appreciate the sort of what's the word? I want you to appreciate how it looks, and that actually on the left hand side of the image, in this case, it's the posterior coming anteriorly towards, and we can use this view to help us diagnose what type of dislocation it is. So in your anterior shoulder dislocation, if you have a look. So you can, what you'll see is that the head of the humerus and the glenoid don't line up on your AP. But at this point, you can't tell whether it's anterior or posterior. So, and then if you have a look, actually, you can see on your Y view that the head of the humerus has fallen anteriorly and anteriorly and inferiorly, and that's how you get your anterior dislocation. That's your diagnosis. See this widening gap. When you have a posterior dislocation, you get what's called a light bulb sign, and that's caused by prominence of the humeral head. Now, I don't have any images of that on this website, but if you look on Radiopedia or Radiology Masterclass, they highlight that very nicely. And when we manage shoulder dislocation, so I think it's important to say that when we manage any type of injury, we always do this A to B approach, and we always take a history and all those things we spoke about your general management of injured patients and fractured patients. And managing dislocations is no different to managing fractures in terms of the principles. The principles are the same. So we reduce it, we immobilize it, and then we rehabilitate it. Now, the way we reduce it, it can be done. So there are multiple. So to reduce a shoulder, there are multiple different techniques and methods. I'm not going to go through any of them because you don't need to know them at your stage. There's something that you can learn as an SHO, and when you become a registrar, if you do orthopedics, you can learn different, or even in the emergency department, you can learn different methods of doing that. But the important thing is that you do it under sedation or an anesthetic. And if you're not able to reduce it in the emergency department with sedation or whatever the analgesia you're using, may that be Entonox or analgesia, they will be required to go to theatre, have a general anaesthetic, and then have a manipulation done and get it placed back. Once you reduce it, you want to immobilize it in a broad arm sling. Now, it's really contentious the length of time that you immobilize it, but roughly speaking, having looked through some of the literature, around 2 weeks seems to be the time for an anterior dislocation. You'd want to immobilize for a lot longer for a posterior dislocation because it's a higher energy injury, and you want to make sure you're giving adequate time for the structures to heal. You don't want it to happen again. And then the big thing with managing shoulder dislocations would be physiotherapy. So the aim of the physiotherapy is to restore that range of movement and strengthen the rotator cuff and the pericapsular musculature around the shoulder. So something you may get asked in your exam about these Bankart lesions or Hill-Sachs lesions. So these occur as complications as a result of repeated dislocation. Okay, so Bankart lesions are fractures of your inferior glenoid. If you see there's a fracture line, you've got this little fragment. They occur, they can occur with recurrent dislocations and traumatic dislocations. The other lesion, notice, is the Hill-Sachs, which is this depression on the humeral head. Now, what that occurs from is that actually occurs from compression from the anterior glenoid when the joint dislocates, and you get essentially repeated depression over this point will cause a depression, causes a lesion to form. And so what you get is this sort of U-shaped depression in the head of the humerus, and that's called a Hill-Sachs lesion. So as we're probably all aware, the rotator cuff is made up of 4 muscles, which contribute and allow you to do your shoulder movements. These are all listed here and highlighted. The main reason I put this in was just to show you the image, and also to show you that increased stability that you get from the shoulder from having these muscles attached. They're not. I mean, rotator cuff pathology is also very common. And these are sort of your most common types of injuries and pathology you can get with your rotator cuff. You can get calcifying tendonitis, which usually affects the supraspinatus muscle. You get impingement syndrome or chronic tendonitis, and what occurs here is you get compression against the coracoacromial arch, and that causes tendonitis. You get inflammation, and then you get an impingement, and that causes pain on shoulder movement. So the way we generally manage that would be with physiotherapy, painkillers, and you can use anesthetic and steroid injections into the subacromial space. Now, if none of that works and you're still symptomatic, then you can surgically decompress and, if needs be, do a tendon repair too. You can get tears in these muscles too, and in their tendons. and they present with pain and weakness and usually will require a tendon repair operation. And then the other thing you can get is adhesive capsulitis, which the pathology is not fully understood. We just know that there are 3 distinct phases that's associated with other pathologies too, including diabetes mellitus. But it's specifically made up of 3 stages. You have this painful stage where you get your onset of pain, which is worse at night. A frozen phase where you get this progressive reduction in movement, and that's usually the first movement that's affected is external rotation. And then you get the thawing phase where you get this progressive improvement of pain and function. Unfortunately, there's not really a lot you can do to manage these patients other than try to control their pain, try to give them physiotherapy. But a lot of the time, this is unsuccessful, and it just spontaneously resolves. The adhesive capsulitis or the frozen shoulder itself can last up to 3 years, so it can occur and can last for quite a long time and be quite debilitating for some patients. And this brings us on to sort of our last case, which covers quite a few different upper limb types of trauma. So we have Miss Astley, a 40-year-old female who presents to the ED after slipping on some ice. She's described the mechanism as falling onto an outstretched hand, and she describes pain at the wrist. Now, you've probably been able to gather from this history that it's likely that she's got a distal radius fracture. Do all frozen shoulders resolve without intervention? So yeah, so it's well described that frozen shoulder is a pathology that can last from 1 to 5 years essentially, and unfortunately what you have to give a lot of reassurance to the patient. And I think the thing with managing these patients is all about managing their expectations, but also providing them with that psychological support as well. Again, coming back to that holistic approach to treating your patients. You can try interventions and they may work, but they're not always successful. So a lot of the time you just have to tell them that it is a frozen shoulder and it will resolve. So I can see a lot of people are answering the question, which is which common injuries can occur following a fall on an outstretched hand. And the 2 common ones, scaphoid fractures and Collies fractures, and we'll talk about both of those. But does anyone know any other injuries that you can get from fall onto an outstretched hand? There's actually quite a few. So unfortunately, a Smith's fracture is not usually one of those. So a Smith fracture is essentially a reverse Collies fracture. The mechanism for that is generally falling onto a pronated hand or a fall backwards onto an outstretched hand. You can get supracondylar fractures. You can also get some radial head fractures, and the other one I think that's quite common is your clavicle fractures as well. So the ones we'll talk about are scaphoid fractures and distal radius fractures. I'm not going to really talk about any of the things. So like I said, there's lots of different pathologies you can get from this one mechanism. But I think the 2 sort of main things to talk about are scaphoid fractures and distal radius fractures. So as you're probably aware, the scaphoid is one of the carpal bones. The carpal bones are shown in the top right for you, all labeled and color-coded. And again, very much like the head of the femur, it has this retrograde blood supply, and that's shown in this image down here. The blood supply is distal to proximal, and the reason that's really important is that if you get a fracture at the waist, which is the middle of the scaphoid, you can get avascular necrosis or non-union of the fracture. If that happens, generally you have to treat those with bone grafts. You'd have to essentially take out the scaphoid and try and replace it with something else. Now, scaphoid fractures are notoriously difficult to see on radiographs. This is actually a very good one, and this shows a very good scaphoid waist fracture. They're not always this they're not always this obvious to see. A lot of the time they can be very subtle. You may see a fracture line. You can't always convince yourself that it's there, even if it is. And this is a problem not only for junior doctors, but also registrars, consultants, and radiologists. So plain films are not always the best way to see scaphoid fractures. A lot of trusts have a scaphoid pathway. at UHCW, that's called the smash wrist pathway. So if a scaphoid fracture is suspected and it can't be obviously seen, but they're clinically symptomatic, they'll be sent home with a below elbow back slab with thumb extension, or placed into a plaster of safe immobilization, and that's essentially to try and keep the fracture together and to prevent keeping it mobile. That immobilization that I spoke about more. And then there was re-X-ray. If a re-X-ray is again inconclusive, you'll request an MRI scan, and that MRI scan is to be done as soon as possible. So at UHCW, the way it works is we would put a request in for an MRI that says smash wrist, and we would usually get a MRI scan done that week, and there are slots that are kept for that. As I said, those complications are avascular necrosis and non-union. Now, scaphoid fractures, the main presentation for them is this pain and tenderness over the anatomical snuff box. And one of the things you can get asked in your exams is about all these, is always about different spaces and triangles and all those landmarks. And I've just popped up the borders of the anatomical snuff box down in the bottom again, just to remind you all. So you've got your extensor pollicis longus tendon forming your ulnar border, your extensor pollicis brevis and your abductor pollicis longus tendon forming the radial border, the proximal border being the styloid process of the radius, the floor being the scaphoid and the trapezium, and that's why you get tenderness over that point, and the roof of it is your skin. Okay, so it's just one thing if you're revising for finals, and then just remember to have a look at your sort of spaces and your contents of tunnels and spaces and triangles. So distal radial fractures are very common, very commonly seen in ED. One of the most common things we see. They're associated with osteoporosis, and they're called usually termed fragility fractures because they can occur very low energy type injuries, like fall on an outstretched hand, low energy in industry. So just to come to a question that someone had about predicting which fracture will go to malunion, which will go to non-union. Not really. So what you can look at with scaphoids is look at where the fracture is, if it's at the poles or whether it's if it's at one of the poles or whether it's at the waist. If it's at the waist, you've got your high risk of avascular necrosis there. So what you're thinking about really is the only way to sort of predict is to think about your blood supply. Okay. And these patients, regardless of who they are, will need monitoring follow-up in your fracture clinic or your hand trauma clinics, depending on where you are, to see whether they have this progression to malunion or non-union. Okay. So back to distal radius fractures, they're associated with osteoporosis, and they're termed fragility fractures for that reason. So if you think about the risk factors of distal radius fractures and fragility fractures, they're the same as your risk factors for osteoporosis. So that's increasing age, female gender, early menopause, smoking or alcohol excess, and prolonged steroid use are the main ones. So as someone has mentioned before, that we've got Collies fractures and we've got Smith fractures as our eponymous names. There are actually quite a few different eponymous distal radius fractures or forearm fractures to be aware of. I've listed 3 of them on the right for you. So your Collies fractures is your most common, not from your Fuchs type injury. So that's your extra-articular fracture that has distal of your distal radius with dorsal angulation and dorsal displacement. Okay, now when we talk about your dorsal angulation and dorsal displacement, we're talking about the distal fragment. Okay, we're not talking about the proximal part, we're talking about the distal fragment. So when we're talking about a Smith's fracture, which is a reverse Collies, essentially, we've got this volar angulation. So instead of having the dorsal displacement, we've got a volar displacement and angulation. And I've got some pictures in a moment of x-rays. A Barton's fracture is another type of eponymous fracture, and that's an intra-articular fracture. So the other 2 are extra-articular. This is an intra-articular fracture, and that's got an associated dislocation of your radiocarpal joint. Okay. So when we think about the Collies fracture, you may have commonly heard the dinner fork deformity being described, and all that's describing again is just what we spoke about before. That's your dorsal displacement and dorsal angulation. So your dorsal angulation being this bit, and then the displacement being the head being moved off. And that describes the dinner fork. And the image that I've got from Radiology Masterclass very nicely puts a dinner fork next to it, so you can see what it means by that deformity. A Smith's fracture, on the other hand, has volar displacement volar angulation plus or minus the displacement, and you can see that you've got this soft tissue swelling, some shortening, and that displacement in this image here. So the most common way to do this is actually to fall onto a pronated hand. So what I mean by that is a common example would be someone holding shopping bags and falling over, and they hit their hand there, or they're falling backwards onto their hand, and that's how you get that type of injury. These two, again, they're just for you to be aware of. There are, like I said, there are lots of eponymous fractures that you might want to or not want to know the names of. So the Galiatsi fracture is a radial shaft fracture with a dislocation of the distal radial ulnar joint. I don't have an image of that, but what I do have is an image of the Monteggia type fracture, which is a proximal ulnar fracture, as you can see here. That's got a dislocation of the radial head. So you can see that that's the dislocation because the radiocapitellar line is higher. The radial head doesn't sit within where it's supposed to be, and you can see that you've got this proximal ulnar fracture that is markedly displaced. So that's about trauma. So those are some of the sort of key trauma and common things you'll see in trauma. Just talking quickly about elective orthopedics and mainly osteoarthritis. So I didn't really want to bang on about this too much, because osteoarthritis mainly affects most of the big weight-bearing joints. It can occur in any joint. It's very common. It's it's the most common joint condition worldwide. And it's usually managed in the community very well by GPs, or as well as it can be, through various methods of pain control and physiotherapy. And then the referrals to orthopedics come in when patients require either joint injections or surgical management, whether that be joint replacements or various other types of surgical management. There's not a lot of this going on at the moment with the COVID pandemic, so a lot of these patients are having to wait. But essentially, this is just a degenerative joint disease that affects the articular cartilage and causes an inflammation, and you get this perpetuating cycle that leads to the loss of cartilage and bone-on-bone erosion. A common question that you get asked in exams is about radiographic features of osteoarthritis in comparison with rheumatoid arthritis. I've just listed the 4 for osteoarthritis in this presentation. But if anyone has any questions on osteoarthritis or anything else, they can ask them at the end. And these are this image is just showing those 4 features. So you've got your loss of joint space, your subchondral sclerosis, which is this white line appearing just under the articulating surface, your osteophyte, which is this little fragment that's appeared here. And you haven't actually got any cysts in this picture, but they can occur too.